I would request the dignitaries to proceed towards the felicitation area, and I would request Dr. N.K. Govind sir to felicitate the dignitaries. For our next session, I would like to invite our chairpersons, Dr. L.K. Jha, Dr. Lovy Gaur, Dr. Anil Motta, and Dr. Amit Gupta on the stage, please.
I think we are towards the end of the session and we have got a wonderful talk. And I would request Dr. Manish Malik to be here for the talk. As you all know, Manish is a wonderful speaker and a highly academic oriented person who is the Vice Chairperson of the Department of Nephrology at Sir Gangaram. He has a lot of achievements and award, and to tell me honestly, I'm sure you can read it over there. The most striking award is the award that he won from the World Brotherhood Organization. And that was for his contribution to society. And that is the beauty of the person that I am inviting. So I request Dr. Manish to talk about Finerenone, a new treatment pillar for the cardiorenal benefits in CKD and type 2 diabetes. Please.
Thank you so much. Thank you, sir, for those kind words. And I have my teacher and mentor, Dr. Khullar, sitting here. So that gives me more pleasure here, sitting here. So can we have my slides, please? All the speakers before me got 30-40 minutes. I just have 20 minutes. I don't know why this is bias against me, but any which ways, I'll try to finish in 20 minutes. So the topic of my talk is Finerenone, a new treatment pillar for cardiorenal benefits in CKD and type 2 diabetes. This is a prototype patient, Mr. Raj, who all nephrologists know, because they probably have been using these slides in their talks. But so this is a general prototype diabetic we all see, 57-year-old, 10 years of diabetes, A1C of 7.4, and an office BP of 138/84. And like all others, Mr. Raj wants to say healthy forever. But the treating physician is concerned about his kidney health. And why is that? As the previous speakers were discussing, that in India, 74 million diabetics, this is 2021 database, now probably we have 100 million diabetics, and out of these 74 million, half of them are CKD. So the disease burden of CKD in India is very, very high. And why is CKD important in diabetes? Because CKD by itself increases the risk of cardiovascular mortality. So if you look at these slides, if you have diabetes alone, then the risk of cardiovascular mortality is twice. If you have CKD alone, it is 3 times of general population. And if you have diabetes and CKD both, then the mortality because of cardiovascular causes is as high as 19%, or 6 times of the general population for that age. So this gentleman got his creatinine and EGFR done, and he was found to have an EGFR of 60. I don't have a pointer here, but you see that he is now being labeled as CKD stage G2, which is on the KDIGO risk map in the green. This KDIGO risk map is very interesting, as I will tell you, but in some time. So now this patient has some CKD, so the treatment now the patient is on is telmisartan with diuretics, and of course DAPA has been added, as should be added for all CKD diabetic patients. As I was telling you, this KDIGO risk map is very, very interesting. This tells you the risk of progression of CKD. This tells you the risk of cardiovascular mortality. And since it has been designed by nephrologists, it also tells you when to refer a patient to a nephrologist. So if the patient sits on the green or the yellow, then the physician can treat them. But if the patient sits in orange or red, then the risk of progression of CKD is high, risk of mortality is high, and the patient should be referred to a nephrologist, and definitely follow-up has to be much more frequent. And how do you put the patients on this risk map? You use the GFR and the albuminuria. So for that prototype patient, using only the GFR to put him or her on that G2 stage was not a good idea. So as I said, CKD is defined by the presence of albuminuria more than 30 or a reduced kidney function less than 60, and you need to do both of these to place the patient on this risk map. So you need to do the eGFR and the UACR annually at least in all patients with type 2 diabetes. So my teacher, Dr. Khullar, is here. My student, Lovy, is there. So what an interesting place I am in. You can all imagine. Anyways, so all the guidelines, ADA, KDIGO, all of these recommend that both eGFR and UACR should be done to properly identify, stage and monitor CKD in patients with type 2 diabetes, as eGFR alone may miss the earlier stages of CKD. And it is recommended that either use a dipstick method or a urine sample, spot sample to the UACR. Over a 6-month period, do 3 tests, and if 2 are positive, then it is a high UACR. 24-hour collection is not required. A spot sample is recommended, and an early morning first sample is recommended. Why? Because when you are walking around in the morning, daytime, your UACR may change. It is lesser when you lie down, it is higher when you stand up. So nowadays it's recommended to take a first morning sample which nullifies all these issues. And of course, no exercise, no infection, no fever, no CHF, controlled diabetes, controlled BP, no menstruation. It is only then when you take these samples for UACR. So this gentleman, his UACR should have been done, and when it was done, he was found to have a UACR of 352, which is A3. So this patient immediately moved from green to yellow to orange. So this patient now has become a moderately or high risk patient actually for CKD progression, for CV mortality, and of course probably referral to a nephrologist also. And why is UACR important? We normally say that the 30 UACR is so-called normal or near normal, but even at this 30 UACR, there's a 2 times higher all-cause mortality and a 2 times higher CV mortality. So even a UACR of 30 makes double the risk of mortality, whereas GFR is not that important, because even at a GFR of 75, which is so-called less than the normal of 90, and even at a GFR of 60, the mortality is not much. Only when the GFR comes down to 45 that the mortality because of CV causes increases. So the albuminuria is much more important for CKD classification. And we all know that CKD and CVD progression in diabetes is because of 3 factors: metabolic, which is poor glycemic control; hemodynamic, which is elevated BP or intraglomerular pressure; and of course inflammation and fibrosis. And all these then contribute both to CKD progression and CVD progression. And that is where the talk now goes on to, that the inflammation and fibrosis is associated with what we call mineralocorticoid receptor overactivation through multiple mechanisms. This could either be ligand dependent because of aldosterone, we all know. This is also ligand dependent because of cortisol. And the problem is that the cortisol inactivation occurs in all cells, but not in the kidney cells and the cardiac myocytes. So in the kidney cells and the cardiac myocytes, cortisol in addition to aldosterone will cause receptor activation. This also happens because of oxidative stress and because of high albuminuria, and all this leads to cardiac and renal fibrosis. And the current therapies, whether RAS inhibitors or the gliflozins, our DAPAs and MPAs, do not address this primary target for fibrosis. And that is why we talk of this drug, which is called Finerenone, which targets the mineralocorticoid overactivation and slows the heart and disease progression in patients with diabetes. We all know that hyperglycemia, high salt load, and oxidative stress overactivate this receptor, and Finerenone blocks this receptor, so it suppresses inflammation, suppresses hemodynamic factors, and along with suppression of metabolic factors, you have heart and kidney protection with this class of drugs. We all are aware of the aldosterone antagonists used in the past, which was spironolactone and then eplerenone. The problem with those is that they cause hyperkalemia. So the usage was limited to either congestive cardiac failure or resistant hypertension, but not to CKD progression. So then they try to design a drug which would block this receptor but not cause the side effect of hyperkalemia or the gynecomastia. So they came to this drug called Finerenone, which is a bulky non-steroidal MRA blocker, and it is more selective against the mineralocorticoid receptor, but it has a very short half-life, 2 to 3 hours. In contrast, spironolactone has many metabolites which are active, so they keep acting for 20 hours. So this drug, because of a shorter half-life, has lower risk of hyperkalemia, and because of the higher selectivity, has lesser risk of breast-related side effects. So to study this drug, they designed these two trials. One was the Fidelio DKD and one was the Figaro DKD. This slide emphasizes that the total number of patients who were studied in Finerenone trial were more than 13,000. This contrasts only to 1,500 patients for the renal trial for losartan, only 4,000 patients for the credence trial. Even our latest EMPA kidney trial had only 6,000 patients. So the point to be emphasized is that this was a robust investigation. So this was the trial. The difference between Figaro and Fidelio was that the Figaro was primarily a cardiovascular endpoint trial, and Fidelio was primarily a kidney failure endpoint trial. The drug dosing was 10 or 20 milligram per day, 10 milligram for patients with GFR of less than 60 and 20 for GFR of more than 60. Now this is the categories map in which we come back to again, and here we see the Fidelio DKD represents the late stage CKD patients who had higher albuminuria and lesser GFRs, and the Figaro DKD was the early stage CKD patients. And the reason behind this design was that they wanted that did Finerenone had cardiac protection even in early stages of diabetic CKD. So even with lesser albuminuria, Figaro DKD showed that even though renal protection may not have been there, but cardiac protection was there. Rather, I was listening to Dr. Rajiv Agarwal's lecture, who is the prime investigator in this trial. He came to our hospital yesterday, and he says that aspirin was invented in 1897, and this is the new aspirin for the heart, which has come after almost 1 century. Is it 1 century? Yes, I think so. Yes, more than that. More than that. So then they compiled the data of Figaro and Fidelio, and then they had this Fidelity, which is the complete set of these patients. If you were to see the EMPA patients or the DAPA patients, this trial covers much more than that. So you had a very, very wide spectrum of these patients. And these were the composite outcomes in Fidelity. The CV composite outcomes were time to CV death, non-fatal MI, non-fatal stroke, or hospitalized heart failure. And for the kidney endpoints were time to kidney failure, or a sustained 57% decrease in eGFR from baseline, or a cause of death was renal. It is interesting that HFrEF was not a part of this study. So this was more of a preventive trial for the heart, not the therapeutic trial. In HFrEF, you have a drug which is spironolactone. So this was more of a preventive study for the heart, not a therapeutic study for the heart. So this was the average patient, a 65-year-old average patient, diabetic 15 years, A1C 7.7, a BP of 137 by 76, a CV disease in 46%, and a history of heart failure 7.7%. So this is a good-looking mean patient, a good HbA1c, a good BP. But even in this set of patients, let's see what the drug said. And of course, 100% patients were on RAS blockade, but only 7% were on SGLT2 inhibitors. So this is what the study shows, that if in the placebo, the risk of kidney outcomes was 7%, in Finerenone it was only 5.5%. So the risk of ESKD was 20% less in the Finerenone group as compared to the placebo group, and the numbers need to treat was 60. This is the heart outcomes. So if the risk of cardiac issues was 14.4% placebo, it was only 12.7% Finerenone. So there was approximately a composite 14% prevention in the CV outcomes, and there was a 22% protection against hospitalization for heart failure, which has been emphasized with that red graph. So Finerenone demonstrated significant on-treatment reduction in the incidence of all-cause and CV mortality versus placebo, and lowered the risk of sudden cardiac death in the intent to treat population. This is what the nephrologists interested in. that at 4 months, there was a 32% reduction in UACR from baseline, which was maintained over the 4-year period. Why is UACR important? Albumin in the urine is a surrogate marker for endothelial dysfunction. So that is why albumin in the urine is not a kidney disease, it is endothelial disease. It's the brain and the heart also. So in Fidelity, Finerenone improved UACR in patients with CKD and type 2 diabetes, irrespective of SGLT use at baseline. So without SGLT2 inhibitors, there was a 31% reduction in UACR, and the 7% patients who had SGLT2 inhibitors, there was a 37% reduction. So this drug had independent reduction as of the gliflozins. So patients in clinical practice, which we all come across, have complex comorbidities or co-medications. How does this affect Finerenone use? So what if my patient has a high HbA1c, has a long-standing diabetes, is obese, is elderly, is on other drugs for the kidney like SGLT2 and GLP-1RA, and of course does have ASCVD. Finerenone has shown a consistent CV and kidney benefit across spectrum of type 2 diabetes and CKD, irrespective of comorbidities and co-medications. Finerenone also shows a modest decrease in systolic blood pressure of 3.7 millimeters. The sexual side effects like breast hyperplasia and gynecomastia, as I mentioned, were no different from placebo. The issue of hyperkalemia has been raised. The risk of hyperkalemia with Finerenone was 14% as compared to 6.9 in placebo, but hyperkalemia leading to permanent discontinuation was only 1.7%, and there was no difference in AKI between the groups. So after listening to all this, what are the takeaways? The simple takeaways were designed again by the investigators by the rule of 5, the 5 fives. So if your potassium is less than 5, you can start this drug. If your potassium is more than 5.5, you should stop this drug. You can initiate if the GFR is more than 25, but then the dose is 10 milligram per day. If the GFR is more than 60, then the dose starting is 20 milligram per day, and treatment can be continued up till a GFR of 15. Finerenone reduced the risk of ESKD by 1/5 and reduced the risk of heart failure again by 1/5. So this is the 5 fives of the treatment of Finerenone. So Finerenone is approved in India with the same indications as by US FDA. It is indicated in adult patients with CKD with diabetes, reduce the risk of sustained EGFR decline, end-stage kidney disease, cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure. There's a trial called FIND CKD, which is assessing Finerenone in the non-diabetic CKD. So those data must come out soon. And the guidelines have included Finerenone in diabetic CKD patients, whether you have the KDIGO guidelines or the ADA guidelines. The level of recommendation may differ, but Finerenone is now the 3rd pillar of diabetic CKD management. The 4th pillar is now also in place, which is the GLP-1RA after the FLOW trial. So now you have 4 pillars of diabetic CKD management over and above lifestyle modification and diet education, which are RAS blockade, SGLT2 inhibitors, Finerenone, and the GLP-1 receptor antagonist. The key points, takeaway points, are that individuals with diabetes are 10-fold more likely to progress to ESRD than those with diabetes. Early stage CKD management is often missed. However, if managed properly, its progression can be slowed or halted. MR overactivation, which contributes to inflammation and fibrosis, is a potential treatment target to slow CKD progression. Despite RAS blockade and SGLT2 inhibitor, patients are at risk of CKD progression. Finerenone, a novel non-steroidal selective MRA, blocks mineralocorticoid receptor overactivation and is different from available steroidal MRAs. And Finerenone has shown consistent CV and kidney benefits across a spectrum of type 2 diabetes and CKD patients, irrespective of comorbidity and co-medications. I thank you all for a patient listening.
Excellent talk.
Thank you, sir.
Dr. Manish. And he's described all predominantly the first like ACE and ARB had been there for almost 25, 30 years plus now. And later on came SGLT, which is also there with us for about 10, 15 years. Finerenone had been recent, not a very old that way drug, which has been used in diabetic CKD, the third pillar which you told. And the fourth pillar is now just getting approved, and it started being used by us. So with all these, we have seen that the progression of renal disease, specifically in diabetic CKD, we can slow it down for few weeks to months to sometimes years and decades also probably. So that we have to see whether this third and the fourth pillar, how they're going to work in over the years. So it was an excellent talk. Any comments from the audience and Dr. Kullu? Yeah.
Question. You know, diabetic kidney disease, EGFR of 30, sorry, albuminuria 30 से ऊपर है तो आप दोगे. There are patients who have EGFR of 40 or 30 and albuminuria is let's say between 20 and 30. I mean, to my mind, pathological process is same. And you said Finerenone is the new aspirin for cardiovascular system. I think Finerenone is also aspirin for the glomerular system because it's the same vascular bed and they have a crosstalk. What is your take on such patients? I know there's no data to suggest that, but what is your take on that?
So I mentioned aspirin for cardiovascular patient. Why? Because the mean UACR was in the 50s for the cardiac subset of patients, where the mean UACR was 500 for the renal subset of patients in these trials. And it was found that even with lesser degree of albuminuria, this drug had a beneficial effect on the cardiovascular mortality. To add to it, in the EMPA kidney trial, the mean UACR was again in the 50s, but you had a renal protection. So as Dr. Jha said, that our armamentarium is increasing. We probably now have 4 aspirins in place for the heart and the kidney, I would say. And the aspirin is probably not the aspirin for the heart now. It is not to be used as a preventive drug, but it is probably for the therapeutic or tertiary prevention. But in secondary prevention, now you have 4 pillars other than aspirin, both for the heart and the kidney. And as you mentioned, the bed is the same, so that even the drugs are the same, because the entire issue is the endothelium and nothing else. Dr. Kullar, sir.
Yeah, excellent talk, Manish.
Thank you, sir.
As always. So few comments and then a question to you.
Only comments, no
Dr.
questions, sir.
So I think that's a very pertinent question which you have raised. And I will, of course, Manish, you've been referring to aspirin. There has been some controversy revolving around aspirin as well. So rather than, I think we should put our faith more in statins rather than, but that's on a different thought process. But when it comes to albuminuria, as you can see, we as nephrologists are all the time bothered, concerned about reduction in albuminuria. And we have done away with few of the terminologies which were very confusing. I personally would not want to use the term microalbuminuria or macroalbuminuria. We have replaced it with moderately increased albuminuria and severely increased albuminuria. So point well taken that there is no doubt and confusion when it comes to albuminuria more than 30. There are trials which like Fidelio. The difference between Fidelio and Figro was Fidelio had patients with more advanced CKD, but Figro had patients with less and wider spectrum. The heart was the primary composite endpoint for Fidelio for these kind of patients because there is an endothelial dysfunction. The point I'm raising, which is very, very pertinent for all of us here to remember is, we do not call even 30 albuminuria as normal.
No.
So the normal albuminuria according to the new guidelines is less than 10. That is something which we have to remember. So what is between 10 and 30, 11 and 30? It is high normal. So which means we are viewing even 11 to 30 with some kind of suspicion. Now KDIGO says, and that's a very interesting read when you go through the recent KDIGO 2024 guidelines on CKD, they say only those who have albuminuria of less than 10 are protected. You can't say the same about people with more than 10. The other spectrum, GFR of more than 105, view it with suspicion, because in diabetics, this is hyperfiltration, they could be in trouble. And especially if they now have albuminuria, it is bad time. for them. So I think I would personally want to give importance even to the way you suggested. It is the endothelial dysfunction first. It is the mesangial hypertrophy first before it turns out to mesangial expansion and sclerosis, and then we know it's too late. Which you will be quite surprised to see the kind of pathology you can see even when the proteinuria is not too much. So yes, short of biopsy, you would certainly want to bring down the albuminuria to as low as possible. The question for you, Manish, is, I'll not spare you, you've done such a fantastic job. As you were saying, we're all the time talking about the role played by SGLT2 inhibitors. AMPA kidney had a small subset where there was no albuminuria. So we have answer to your question as well via AMPA kidney, where they had a patient between no albuminuria, GFR 20 to 45. And there also, again, it was found to be useful. Now, we have talked about RAS blockers, we have talked about SGLT2 inhibitors, you have shown a beautiful data on Finerenone. Now, my question to you is, we are targeting mineralocorticoid receptor antagonists. And the problem here is the two phenomena which we always remembered in the context of Conn syndrome, the aldosterone escape, and now you also are viewing aldosterone breakthrough. Now, my question to you is, aldosterone has its effect even via non-MRA pathway. So what happens is supposing you are blocking mineralocorticoid receptor there at the level of the kidney, and you are now causing accumulation of aldosterone, you are giving it a chance to have its action via so many other pathways as well. Do you think there is data that it has not happened in the real world for quite some time? If that is the case, would you want to repose your faith in directly inhibiting aldosterone synthesis? Because the next molecule is going to be the aldosterone synthetase inhibitors, which is going to block aldosterone. They are specific now because the previous ones were also blocking cortisol and they were not welcome. And now you have very specific aldosterone synthetase inhibitors like baxdrostat and others, which could be the game changers. And whatever shortcomings we are seeing, or maybe we can expect with mineralocorticoid receptor antagonists, that's Finerenone, and a whole lot of other, Cardiorenal and whole many others, possibly may not be seen with aldosterone synthetase inhibitors.
So I second your point. The whole research has been on filling those gaps. So probably the last gap probably which you have mentioned, or maybe the last gap will be filled by the drugs you have mentioned. But then there's never a last gap filler here. People thought that RAS blockade was the it thing. Then they found a huge gap of patients not protected. So I think it's all an evolving field, and nobody has the final answer to it.
Gap is there, Manish. What is going to happen with aldosterone inhibitors is the angiotensin 2 will be unprotected.
Of course.
So angiotensin 2 will then have some possibility. So I think we are going to get fascinated by our knowledge of physiology, and now the time has come where we are now evolving via what we have learned in our physiology classes. Once again, a beautiful job.
But the takeaway point is that cost or side effects should prevent us from using a wonderful drug. Hyperkalemia is manageable by diet modification and by the newer potassium binder which should be coming in some time. Cost of dialysis is immense, we all know that. So an 80 rupees tablet, I'm not marketing it here, sorry, my apologies for that. But or GLP-1 RAs. So the cost should not prevent us from initiating these medicines, and we all know we live in a country where the cost comes down very fast. Even that Dr. was saying that in the US the cost of one tablet of Finerenone is $20 US. We have it for 80 rupees. Once a generic comes, which will come in some time, we'll have it for 8 rupees. So we should all start getting into practice, and more importantly, this data shows that most of these patients are yours, not the nephrologist. So it is the internist or the first level care providers who has to start initiating treatments on these drugs rather than wait for the disease to advance. As sir said, it is the early stages which have to be targeted. So let's say a GFR of 60 with a UACR of 50 or 60, let's say, will never come to a nephrologist. And you will never want to send them to a nephrologist. But then you should initiate them on this class of drugs, either Finerenone or semaglutide, both of which we have enough experience to use, but probably still not using it the way we should be using it.
Dr. Manish, I wanted to make a comment that this study, Fidelio, they had only 4% patients on SGLT2 inhibitors.
6.7.
6%.
Total was 6.7 in
6%.
fidelity.
Even the flow study which has come has now 15%.
Yeah.
So with the robust data of DAPA CKD and AMPA kidney, now doing any study without a SGLT2 inhibitor, probably it should be like a baseline, like a RAS blockage. SGLT2 inhibitor should be also a baseline. And the benefit which we have got with this, this one, will it be translated then also when you have a SGLT2 as a baseline? I know there's a study going on that, but
So I was coming to that. That study is going to stop in 3 days' time on 31st. We'll call it. This is by the name confidence trial. So which is addressing exactly the issue you raised. There were just 6.7% people because SGLT2 inhibitors were not really in vogue during 2016, 17, 18 when these studies were being carried out. Flow trial, again, we were part of trial and again, all these trials including DAPA CKD, AMPA kidney, and they were prematurely stopped because of overwhelming response benefits. Confidence, flow had 15%. Confidence trial is what we are talking about. 3 arms. One is over and above RAS blockers. One is Finerenone alone. Second is empagliflozin arm. And third is a combination of Finerenone and dapagliflozin, which will tell us whether there is any point adding one on top of that. So we will get the recruitment is going to stop in 3 days' time, 6 months of study period, and 30 days of washout. So we'll get the answers hopefully in next May.
There was subgroup analysis done for those 6.7% patients, and who were on both, and hyperkalemia was less.
Yes.
Even in that number of
Yes.
patients, and the benefits were there.
Yes, agreed. So a combination, so as Dr. Khullar said, in the trial, confidence also, everybody is getting 2 pills. So when you have the 2 pills together, probably advantage will be much more, and definitely hyperkalemia is much less, so yes.
I think with due regards, we must thank Dr. Manish for a wonderful presentation
Thank you, sir.
and such a wonderful interaction.
Thank you, sir.
My compliments to everybody and to the whole house for being interactive, so interactive. In the rest of time,
Yes.
I really thank you on behalf